Good morning, everybody, and congratulations on having made it through last night's dinner and still being here to tell the tale. On the 7th of July, Eric Sigmund from the Czech Republic became the first person to register for the conference. And that made us happy because we knew that people were going to come to Glasgow. We just didn't know how many. On the 22nd of September, when Fiona Dobby from the UK became the 1,000th person to register, we could stop worrying. I'm delighted now to introduce this plenary session on reaching the most at-risk populations, and the moderator of this session, Isabel de la Mata from the European Commission. Thank you.
Good morning. Thank you very much for attending this plenary on the reducing inequalities in health and healthcare, and focus in chronic diseases and the burden in the European Union, mainly, even if I think that we also talk about expanding that to Europe in general. So even if the health of the population, the overall population health has improved in the last year, in the last century, and even more in the last decades, we don't see still that this improvement has been experimented equally in all the member states of Europe, in all the countries. This is true for all health in general, but we begin to see that this is really true for the burden of chronic diseases, and that we have inequalities between member states, inside member states, that this is an issue that is not improving with the time. We know that the health inequalities are influenced by multiple factors, and that not all of them are related to health, that the living conditions, the working conditions, the education, the physical activity and the diet that is linked to the money that you have to spend on food and on your free time, that the risk behaviors that sometimes are also linked to your situation in life, the alcohol consumption, the drug consumption, and the access to healthcare, to health services, is influence the health that you have, and has an influence in the inequalities that we see. So addressing the inequalities on health and tackling the burden of chronic diseases are important and are important for everybody as cross-cutting health priorities. And it's important that the member states work together also with the international organization and with the stakeholders, that everybody has something to say to improve the access to healthcare and to fight the health inequalities. Specifically, the European Commission, in the framework of shared management, support the member states in making better use of the European Social and Investment Funds for activities that reduce health inequalities. So the investment fund and the European Social and Investment Fund is not something as it used to be at the beginning, just to build hospitals on healthcare centers, but can be used in a larger scale to fight health inequalities in general. We work in that area with the regions, we work with socioeconomic groups, we encourage the use of integrated community-based approaches to provide social and healthcare services. And we are going to discuss today with these four speakers that we have around, the most important aspect that should be considered to respond to the expanding need for the prevention and care of chronic diseases. Now we know that this is very fashionable to talk about chronic diseases. We have had many conferences around, and we are focusing in different aspects of the chronic diseases, but not always so present in the debate are the needs of a specific vulnerable population or population at risk in vulnerable situation, and the fact of chronic diseases. Because it's true that most time we focus on communicable diseases for some groups of the population. Sometimes we focus on health determinants for them, but not always we focus on what we do when they are already sick. How are we going to manage the chronic diseases in vulnerable population? So for that we have 4 speakers that are Andrea Paulikova, European Service Development Manager in the Scottish Centre for Telehealth and Telecare. We have Ilmo Keskimaki, Research Professor at the National Institute for Health and Welfare Division of Health and Social Services and Professor at the University of Tampere. Ricardo Battista Leite, Member of Parliament, and Gauden Galea, and WHO Director of the Division of Non-Communicable Diseases and Life Course in Copenhagen. First, I'm going to give the opportunity of make 3 minutes, maximum 4 minutes, introductory remarks to the 4 of them. And then we will enter in a dialogue with some questions that we submitted before. And if time allows, we will enter in a dialogue with the public. So we will go from the issues to the responses that international organizations are given. So I will begin with Andrea Paulikova first, and we will move 1, 2, 3, 4. Okay, Andrea, 3 minutes.
Yeah. Thank you very much, Isabel. I will probably also start with this positive message that you also mentioned in your introduction, that actually the fact that people in Europe live longer and that the life expectancy has increased over the last couple of years actually underlines the fact that there have been major improvements in the public health and that we haven't necessarily done everything wrong within our healthcare system. Where the problem currently is, or the problem we currently face, is that our health and care system haven't been necessarily designed to deal with the consequences of this living longer. They haven't been set up to ensure continuity of care. They haven't been designed for communication and dialogue between different care professionals and different care settings. And more importantly, they haven't been designed for more active participation and greater responsibility of individuals to take care of their own health. Therefore, if we really aim to tackle the burden of chronic diseases meaningfully and thoughtfully, we need to change. We need to change the way we think, we organize and deliver our services, because we can't tackle these new challenges and this burden of chronic diseases with the old way of thinking. And in Scotland, we do recognize this need for a change, which is clearly articulated in our Vision 2020, where we really aim for the healthcare system which puts people at the center, at the heart of everything what we are doing. We want to have the healthcare system where everyone lives longer, healthier lives at home and community settings. And equally, we want to have a healthcare system where health and social care is fully integrated, as we believe that this is the most effective and efficient intervention to tackle the challenge of chronic diseases. Obviously, the implementation of such a vision is not easy, and it brings a couple of challenges, and I'm sure that we will have the opportunity to explore them as we go during this session. But I would like to maybe leave my introductory statement with the 2 messages, that it's about shifting resources and shifting responsibilities if you really want to make a progress towards more effective and efficient care for our people.
Thank you very much, Andrea. So, Ilmo.
Okay, so I don't have any new messages, but I reiterate a couple of old ones. So if we consider the health systems in Europe, they are still, even if we have all the government has accepted the high protection of health for the citizens, the health systems are not following this principle. There are many health systems which are not universal, which are there are gaps in provision of services to poor, to ethnic minorities, to unemployed, and this discrimination is also carried over the borders. So that as we know, as we have heard for instance, in this conference many times, for example, the situation of Roma people in Europe is unacceptable. So let's do what we are teaching to do, what the government are telling they are claiming to do. So let's organize the health services which is open to all and which is really providing high quality services to all as what is the principles in the most of the systems. So then we are speaking quite a lot about patient-centered care, but in fact if we are looking the health systems in Europe, in many countries, in my own country, in fact it's built for the organizations, it's built for the professionals, for their benefit, not for the patients. So it's this is what we know quite well. So there is a need, as previous speaker said, there is a need for integration, integrated services which are serving the patients, not serving the doctors or nurses or organizations, the leaders of these organizations or commercial interests, whatever. And the third point is that, in fact, as we know, the chronic care is not very high quality, in fact. So of course, taking care of patients with chronic conditions, it's very difficult. Doctors know it, the professionals in healthcare know it, but still, if we consider how the care system, for example, guidelines are implemented, they are poorly. It's poorly done. There is not really good implementation systems for guidelines. There is and it's not a big surprise that the quality of chronic care, balance of their condition is relatively poor in many countries. On the other hand, there are good examples where when this implementation is done well, also the quality of care, care results are good. So let's do what we teach, and we don't need at the moment very many new tricks in order to improve the situation for particularly the poor and deprived people, our deprived patients.
Thank you very much, Ilmo. Ricardo.
Thank you. I'm going to speak over there, if you don't mind. Quickly.
Okay.
I'm sorry, I hate tall chairs except in a Glasgow pub, so I'd rather speak here. Good morning to you all, and I'd like to start by thanking the European Commission and the organizers for their kind invitation, and to congratulate you what is turning out to be a very productive meeting and hopefully a policy changer meeting. We are here today to discuss on how to advance health equity towards reducing the chronic disease burden in the EU. And to advance as we all desire, we must put all European politicians on board. And to do so, we must be clear on three simple facts. Chronic diseases are responsible for 86% of all deaths in the region. They are the main cause of disability and morbidity, and we spend over 700 billion euros a year, year after year, a number that will grow on chronic diseases. If that's not good enough to convince your politicians, well, I have to say they're probably not that good. As you all know, during the 20th century, we lived what is called the scientific era, that boomed and gave us sound evidence on how to solve health problems. And now, in the 21st century, we are living in the post-scientific era, in which, despite the fact that we have the power of science on our side, social factors like discrimination, poverty, costs are blocking our actions. That's where politics plays a central role to overcome those barriers. It is the role of a politician to put science at the service of the people. But our main problem is clear, and I've said it before. In most European countries, we don't have health ministries, we have disease ministries. Just look at the numbers. 97% of our health budgets are spent on treatment, when less than 3% are invested in prevention. We need a value-based health system in which health outcomes become our main endpoint. A system in which disease prevention and health promotion are put at the core. When we have people who are sick, they are not working. That has a direct impact on our economic situation, on our productivity index, and so we need to change the focus from just looking at health as expenditure, but at health as an investment to attain a sustainable future. But there is more to be done. To achieve such goals in the future, we need to make sure that everyone in every area of government, from education to finance, works every day with the common goal of health for all. However, we know that we are still far from getting there. The WHO and others have pushed for health in all policy, which I fully agree with. Unfortunately, though, health in all policies has become more of a buzzword than a reality. Being here in Scotland, allow me to use an analogy to try to get my message through. Health in all policies, ladies and gentlemen, has become the Loch Ness Monster of the European Union. And I'll tell you why. Everybody talks about it. Many people believe in it. Some have allegedly seen its head or its tail, but no one has seen it as a whole, and most probably, I'm sorry to say, it doesn't exist. Ladies and gentlemen, we need health in all policies. The European Commission and the member states must fight harder for it. And to do so, we need to give more power to health ministries. We need to give more power to the health institutions in Europe so they can intervene at the member state level to assure the implementation and the funding of a proper European public health strategy that embodies the spirit of solidarity defended by our founding fathers. I know this is all easier said than done, but have no doubt, a healthier future in Europe depends on our actions today. A couple days ago, Margaret McCartney said here at this conference that we had lost the battle for health in Europe. But I say we haven't lost the war. Let's take things up a beat and set bold goals. As I've told the previous commissioner, I tell the European Commission today, you have this room full of soldiers, me included, willing to fight for a healthier Europe. Let's start making change happen. Thank you very much.
Thank you very much. It's true that we have a momentum during the Portuguese presidency and the Spanish presidency to work on inequalities on health, the Finnish presidency on health in all policies, and I'm not sure if we have already missed that momentum or we are still on time to recuperate and really, I don't know if continue or do the work on that we need to do in order to fight the inequalities and the vulnerable groups. So, Gaudens, from the WHO perspective.
Thank you, Isabel, and I'll stand. My center of gravity is a bit too far forward, and I have this sense of falling on my face all the time. I prefer to do it from the words that I say rather than physically, so less a clown and more a challenge. Thank you, Ricardo, for the rousing suggestion on the Loch Ness Monster. I'd like to make 4 quick points. One is, I hope this is not too much like heresy. I'd like to defend the average a bit. We pit the average versus the gradient in the discussion. And I love the fact that the title of this conference is Mind the Gap, not Mind the Gradient. I really think that we should be looking to improve both. And the point has been made that over the last 30, 40 years, within non-communicable diseases, we have seen major advances in Western Europe, such that in practically all countries where we have any data, poor people today die at much lower rates than rich people did 20, 30 years ago from the same diseases. The average pulls down the whole population, and the population approach is to shifting the distribution in the population is at least one index, is what is the average, what is the measure of central tendency. So in the discussion between absolute and relative improvements in health, I think both are important, and we need to be looking. If I were 70 years old and you gave me the absolute guarantee of another year of life, it would be extremely important and not relatively so. It would be the absolute and the average are important achievements that public health has made, and we must be extremely important that we don't pit it against an ideology that makes it sound like it is less important or unimportant. It is one of the great victories of public health, and we need to celebrate it, as well as to realize that that is not enough. We need to look to see how health is distributed. And that's my second point. When we try to do a situation analysis across the 53 member states of the European region in WHO, we found that the vast majority are unable to disaggregate data on non-communicable diseases, either risk factors or the diseases themselves. So they know what it is as a whole, but they don't disaggregate. Now, the sociologists among us know that social class is a complex phenomenon, and it is not easily reduced to simply saying I'll measure sex or social or educational attainment or employment status or income, but in reality it's more complex than that. My plea, if there was a recommendation coming out of this, is to really ensure that at least we do the simple part and we try to disaggregate by age, sex, and some major variables. When we do so, we find that there are some surprising vulnerable groups. We did a health systems assessment in a number of countries, both within the European Union and in Eastern Europe, and we found one surprising vulnerable group, men. In fact, the differential between men and women is so great, especially in many countries of the east of Europe, that we're actually thinking of next year finding some way of prioritizing the missing men and identifying what is it that drives them to drink so much, to smoke so much, to not use health services so much, and to die so much more than women. Do I have two final recommendations? If I were to go forward in a public health community, I think two areas for improving inequity must lie in improving our skills as a public health profession. The Loch Ness Monster might not exist, but it won't be brought to life. Health and all policies won't be suddenly materializing if public health community is unable to work really within other sectors. We had a session at this conference yesterday where we looked at fiscal policies, a hugely important intervention that is largely ignored by many countries of both the West and in the East. There's a lot of scope for extra benefit to be had from that single intervention that we are still not taking advantage of. But if we are going to do that, we really need to engage with the language of tax. We need to know how to go into the other ministries. We need to know how to address the arguments of industry. We need to know how to make sure that the tax instruments that we create are not regressive, and how to compensate for any regressive elements that they have. So in order to do this, it's not enough to simply call for health and all policies. We need to have a public health community that is aware and has the skills to work on a specific other sector in a long-term engagement that makes a difference. My final point is, apart from the skills, we need to find important points of intervention in a person's life, and if there was a candidate for the long-term improvement in inequalities, my candidate would be early childhood development. Maybe it's a cliche to say this, but clearly it's an area, it's a time of life where a good intervention could result in benefits across the whole range of public health, not just in chronic diseases. That's my opening. Thank you.
Okay, thank you very much. So there are three common points that have come in all your presentations. That could be that the health systems are not prepared for the challenges that they have now, that we need health professionals that have the skills and the awareness, and not only the value, but the need to work on health in our policy. Andrea, used to talk about best practices, and do you think that it's possible to really learn from what the others are doing and implement these good practices? And do you have examples of how to apply that to integrated care?
When it comes to the approaches to integrated care, we see that there are number and diverse approaches across Europe. We see the interventions that tries to provide linkages between different care settings, or they aim to ensure continuity of care, or they are even highly more ambitious, like in case of Scotland, where we aim for the full integration of health and social care services. And the number of these approaches and the diversity of these approaches, for me, underlines two facts. First of all, there is no one-size-fits-all approach. So we can't take one model from one country and say, let's all follow this one model. But what we can do is to learn from the diversity of these approaches. We can learn from each other. And it doesn't have to be necessarily the learning from the success stories and from the pioneers across Europe. We can actually learn much more from the failures, because I'm sure that you don't want to waste your money and time repeating the same mistakes. So when it comes to this question of replication and scaling up of the integrated care solution, I particularly am a big fan and in favor of the European Commission response to this problem, which is in the form of so-called European Innovation Partnership on Active and Healthy Aging, which is the European platform which mobilizes hundreds of organizations across Europe working together for the integrated care in Europe. And as a part of one of the key activities of this group has been the collection of the good practices which are available for all of you to learn and share your own evidence and experience with the group. With the others. The second element that comes with these numbers of approaches for me is the fact that indeed there is a recognition that we need the integrated care, and there is a political recognition to implement the integrated care solutions as well, because you would probably all agree with me that you can have hundreds of good practices, but if there is no political willingness, you will never get this good practice implemented. But at the same time, I must slightly disagree with the statement that we need to give more powers to politicians. I believe that the powers when it comes to the healthcare needs to be in the hands of individuals, in the hands of each of us, and we need to get the tools and processes in place so that we can participate much more actively in the delivery of care. It needs to be the care that is tailored to our needs, not to the needs of politicians or healthcare delivery organizations or healthcare professionals. And I believe that Scotland, with its approach of combination of bottom-up approach, so listening to the people needs, and top-down approach, with the fact that we are really aiming to make integration happening through the act on integration, is actually a very effective response.
Thank you very much. You have talked, Ilmo, about the health systems that are not prepared, that they are not following the principle. Which one do you think that are the main challenges that the health system have really to focus, and how they should work in an intersectoral way with other sectors?
Okay, so as it was said just by the previous speaker, there is probably no one solution, because the healthcare systems frameworks where the systems in different countries are working are different. But we know about the principles. We know that there is a need for integration. There are many reforms heading to that direction in England, in my own country, in the Nordic countries, in the Netherlands. In fact, we know quite a lot of solutions. Of course, as said, there is no one right solution, but as said, I think that the integration of services, not only health services, but public health promotion as well as social services, that's the direction we should go.
Okay, thank you. Ricardo, how do you think that we can balance the challenge between ensure the quality of care and the value for money, the fact that many member states are suffering for the economic crisis and that the budgets are decreasing, especially for health, and that those budgets that are decrease. At the same time, encounter that we have more people in a vulnerable situation. How can we balance all that?
Thank you for the question. Coming from Portugal, I'm very sensitive to what externally imposed cuts means. As you know, we just finished the Troika program in our country, and we're proud of complying, but we did it with a lot of sacrifice of our people. And the real costs of that kind of intervention will only be foreseen in the future. And that's one of the problems. I mean, when you mix public health with politics, it's hard to convince people about results when you can't have them immediately, especially not within the same political cycle. However, and going straight to your question, I feel that the European Commission and the European Union as a whole really has to prioritize what it wants to do when it comes to health, and public health in particular. Because we cannot have constant discussions about how we need the Commission to do more, but every time we have a meeting with the member states, everybody says, don't touch on my health. Yeah. Okay, so we really need to find a fine balance. I think public health is very, very particular because people cannot easily understand how there is a global interest, or at least a union-wide interest, to have more intervention from the Commission side. And so that would allow, for example, for us to invest identifying what our priorities are, identifying what the gaps are that we need to close, identifying those vulnerable populations. We can really get the science to understand how we can reduce that gap and apply European funding directly to that. Because as you know, and my country was an example of that, many others were too, we applied a lot of, the only funding we had for health was to build hospitals and things like that. So infrastructure, or either to build railways or to build roads or highways. And at the end of the day, maybe it would make more sense to have European funding for prevention strategies, for treatment strategies that can prevent other problems in the long run. That's having a public health strategy that I called for in my initial statement. And to do so, we really need to get all the member states focused on the same direction. And I hope and I believe that the new commissioner has this view. As a member state, as a member of parliament in a member state, I've been pushing for this and I will continue to do so.
Thank you very much. The new commissioner has already made clear that health in all policies is one of his priorities and is one of his view of how to work in health, coming himself from a country that doesn't have the best results in health, if I can say like that. I think that he is quite aware of the situation and of the problems, and that he will be happy to work on vulnerable groups. And the Commission has been in the last year making this issue of access to healthcare, discrimination, vulnerable situations, vulnerable groups already clear in the last year in Glasgow, in March in Brussels again. So we have already paved the way to the work that we will continue between that. But I'm not going to focus on what the European Commission is doing. As being the moderator, I could be like making propaganda. So Gauden, well, you have a role of working with the member states from an overarching situation, but how do you think that in practice you can work with the member states that are more touched because of the crisis and with the discovery that you have been making that, for example, men or other specific group could be more at risk, and how could in practice, the WHO helped the member state to solve this situation?
Solving the situation is
work
at solutions. One is to try and model the work. We're talking about chronic diseases, but in one sense, one tries within the WHO approach to show that there is a linkage across all the different areas of public health. And within the Health 2020 framework, there is the the two top strategic objectives of addressing social determinants in order to reduce the inequalities in health and to promote participatory governance. To some extent, a lot has been said already on addressing the social determinants in the panel. It's also important to work with member states in order to understand how is health governed, not just in the health system, which is an important, healthcare system, which is an important component, but in how are all stakeholders involved? What are the relations with the private sector? Where can collaboration happen? Where does it need to be at arm's length? What is the role of the state versus the individual? One particular trend in the area of population prevention for non-communicable diseases that I see is that in Western Europe, there is increasing discussion of language like nudging the population or increasing awareness and staying away from state intervention. And I think raising the importance that the state has in addressing social determinants. The market will not naturally go and support vulnerable populations or promote their or promote health among them. There is, if it is not the responsibility of the state, then whose is it? So the governance for health should be an explicit discussion at the top level of policy making in the country, and Health 2020 tries to achieve this by generating a certain amount of debate in country by country. Policies are not just made broadly on health. Then one needs to look at specific policy areas. And another, I hinted at this at the beginning when I spoke about fiscal policies, for example, in the area of tobacco. We find that we have to repeatedly, as new generations of practitioners come into the field, we have to repeatedly go into raising the skills and building the capacity to work in individual sectors across with other partners. Much success is being registered across Europe. Countries are raising prices of unhealthy commodities, changing the formulation of food products, reducing salt, removing trans fats, dabbling with the discussion on control of marketing of foods to children. So there are quite a number of individual, more narrow policies that are beginning to appear and to become more and more prevalent in the discussions. A third area that I would highlight briefly is the importance of health systems that guarantee universal coverage for a basic package of essential health services, especially at a time of austerity or cutbacks. The importance of making the business case for a sense that protecting the health of people at all stages of life, maybe with special attention to the early childhood period, as I referred to earlier, is an investment in the future of that society. So it is not just a matter of saving money, but that even within the challenges of austerity or financial cutbacks, the importance of an essential package of risk pooling, of proffering people financial protection from the challenges of catastrophic costs of healthcare are really an important value that states should take on board. Health 2020 tends to touch on all these, and we would normally find that within WHO, developing a relationship with a country and its partners and trying to highlight all these areas, among others. I highlighted earlier the surveillance part, so I won't repeat it.
Okay, thank you very much. Ilmo, the health professionals have been mentioned several times. Being at the university, have you seen any difference between the students at the different levels and the awareness about the impact of the chronic diseases, the impact of the different health determinants, the vulnerable groups now and previously? I will not say, I don't know how long have you been there, I will not say previous generations.
I don't know if the Finland is this case in a good example because due to reforms in medical education, I think that they are nowadays, at least if we consider the content of the teaching, they don't get so much, how to say, for instance, public health, public health teaching than they used to. For instance, I used to get. On the other hand, because of this content of promotion, epidemiology, public health, those skills of which are related to public health, they are integrated to clinical topics. That may be helpful, but I think I have great trust in young students, and they quite often they surprise me that how much they know compared to my own time at medical school.
So before we had no training at all, no awareness at all in public health, and at least now they have some awareness, the general students, we are saying. Andrea, when we talk about the health budgets, we always put the focus of 3% of budget dedicated to health promotion, prevention. That is nothing. That is very, very few. At the same time, it's true that we already have the people that suffer from diseases and that we have to treat them, so to dedicate budget to them. And at the same time, we always blame the technologies, the telehealth, telemedicine, and all the different technologies that, yes, maybe will be the solution in the future, but now they are costing a lot. How we can manage this situation?
Well, talking from the perspective of Scottish Centre for Telehealth and Telecare, we really truly believe that if technology is deployed meaningfully and thoughtfully, that it's actually the key to transformation. But I would really like to highlight that we don't see the technology as a standalone solution that will tackle all our challenges. It's just simply the tool and enabler that can help us to organize our services more efficiently and more effectively. And to tackle the issue of the money, for us, like when I say that technology is really the enabler and as a tool, it means that if you want to equally address the challenge of the cost, you need to make ICT application as part of your service redesign. And service redesign starts with the education and training of your service users, of your healthcare professionals. And the moment, like every evidence so far from the implementation of telehealth and telecare programs across Scotland shows that maybe you can't everything calculate in terms of the money, but if you ask service users how much they are satisfied with the delivery of care via the ICT solution, there is, in most cases, positive feedback both from the service user and from the healthcare professional. So the moment they know and they see the benefits of the technology being part of their daily life, they have the confidence to use it. They actually become champions of themselves to go to the direction of technology-enabled care.
Thank you. Ricardo, I have a last question. That is, how can we reconcile different policies? Gauden has mentioned reducing salt, tobacco, etc. When we have the salt industry, for example, that refuse to recognize that salt could be bad for health. We have the tobacco industry that has been fighting, as you know. We have the alcohol industry talking about the good things of alcohol. We have and a politician has to reconcile all these different, having money on one side, having the industry in the country develop to have more employment also, and the impact on the health of the citizens.
It's a difficult question, but I'll try to answer in a clear fashion. We need, above all, that the European policy be less permeable to any kind of lobby from the industry. It is unacceptable that we still have below 18 minimum age in certain countries for alcohol consumption or for tobacco consumption. I can't understand, with so much science behind the plain packaging, why that isn't happening in tobacco. So there are clear, this is another example of how science is clear, but politicians have been unable to put science at the service of the people. But getting back to what Galden was saying, and I think it's extremely important in trying to answer your question on the social determinants and financing, we need to do what I mentioned before, we need a values-based approach where financing is focused on health outcomes. Because what happens now in most European countries is we have the public health part closed in a different silo, which is in a department or somewhere else, and then you have the whole of the rest of the health system that is taking care of continuous care or acute care. And public health has to be like an octopus, you know, you have to be everywhere to be able to work effectively. And to do that, the only way to change the way the health institutions work is to change the financing model, in my opinion. Because people at the end of the day do what they're paid for. So if you're paying institutions not based on the number of surgeries or the number of consultations they're doing, but based on the health outcomes of their population, I guarantee you they will be more worried on what they're doing on prevention than they are today. Because nowadays, as you know, hospitals, regional administration areas of health, they're all very focused on their administrative, bureaucratic procedures and outcomes, when they should be looking at if the population is healthy or not. I'm a medical doctor. I come from the field of infectious diseases. At the end of the day, I don't care how many consultations my patient had at the hospital. What I care about is if the patient is better than before, if the patient is cured if possible, or if cure is not possible, getting access to the best health possible. And that is what we have to focus on. And we need to really change our finance model because, once again, people do what they're paid for, and we need to pay for them to fight for health promotion and disease prevention.
Thank you. So, as I read in one of the tweets, you are advocating to change from a diseases ministries to health ministries.
Exactly.
And you have a lot of work to do at the Parliament,
we all do,
for sure. So we have 10 minutes that I will open for questions from the public. Is there any question? There, I don't know if a micro is. Yeah. It will be useful to have someone going with micros, but okay.
First of all, is that working? Yes. My name is Florence Bertoletti. I work in Brussels for the Smoke-Free Partnership. First of all, I wanted to say thank you very much for a very, very inspiring presentation. And I have a question to you all, which I've mentioned yesterday, and we'll have the courage to ask again. First of all, I'd like to borrow a standard phrase of the WHO, which says that things that do not get measures do not get done. And we live in an environment where everything that is being done in politics and its ideology is growth. And growth uses GDP. Now, there is a movement which is calling for beyond GDP. And unless we, as a public health community, join this beyond GDP, which is supported by great economists such as Stiglitz and Amartya Sen, and ask that the impact assessments of everything we do include public health measures, we won't make progress. What do you think about this?
Who answers? Volunteers? Ricardo? Okay.
I mean, basically, if I got the question right, GDP is not a good enough index. And I fully agree, actually. Before getting into this session, I was having a discussion with Portuguese colleagues of mine precisely on this issue. We need to have, if we are able to acknowledge, as Gordon has reinforced in this debate, the importance of social determinants, then we really need to find a way to include social aspects within our indexes. However, I think that's a very hard task. That's something the academia and the health organizations really have to focus on. But in the current period, what I can say in talking about vulnerable populations and in talking about low-income countries, GDP is still the best index we have. What is happening, though, and I'll give you a quick example, is when we talk about access to innovation, because of international reference pricing that exists in Europe, countries like my own in Southern Europe that are poorer, the pharma companies end up saying, oh, we can't lower the prices because, or else the Northern European countries are going to use you for international reference pricing. So we really have to discuss if it makes sense, if we really believe in solidarity among the Union, if it makes sense not to divide us up in tiers in which people, the member states are able to work among them based on at least GDP, which is the best index we have. And so if we are not able to at least adapt what we have in the sense that we can make access easier to new drugs and to new treatments and to new technologies, I am very much afraid that inequities, disparities among member states will just grow because we are just starting of what will be the near future of high-cost treatments, of high-cost technologies. And so if we are really wanting to solve the problem, we need to find a solution because the current solution does not work. In the future, I think you're straight on topic. Academia and health institutions will have to find a way to bring in the social aspects so that the true assessment of the member states is more holistic and can really correspond to the health needs of those countries.
Okay. Anyone else? Or? I'm fine. Okay. Next question.
Thank you very much. I'm Alison McCallum. I'm the Director of Public Health and Health Policy for the Capital Region of Scotland and the Chair of the Scottish Directors of Public Health Group. So yesterday our new Health Minister, Shona Robeson, was announced by the new First Minister, Nicola Sturgeon. Since I have you here, what things should I put in my letter to her to ask for and to join with her in trying to achieve in the first 100 days?
Any comments?
Minimum unit pricing for alcohol.
Yeah. Anyone else want to make any comment? No.
And in terms of inequalities?
I think that for me it would be really this statement that we can bring. We probably are aware of the Christie report and the main message of that report that the effective services really need to be designed with the people and for the people. And especially when we talk about the health inequalities, those people have very often different needs that from the wider population. So if we want to make sure that the care for the most vulnerable group is delivered in the more equal way, in the same quality of care, then we really need to make sure that we try to find the mechanism how to listen more to the needs of the vulnerable people and make them included.
I just I have to say that we are aware of the issues of the vulnerable, isolated people were mentioned before, especially men. And for next year, we are preparing a specific study on that and work that we hope that will bring in 1 year time, if possible, some solutions, some answers and some discussions to this situation. We know that there are regions in the European Union that people are more isolated, geographically isolated, physically isolated. There is another isolation that can take place even in the bigger cities. We are focusing a lot on elderly people, but it's not only elderly people, it's not only migrants that could face those situations, and it's because of that we are going to make that study that maybe we hope that will bring additional responses. So, any other comment you want to make?
No, I'll just add on an
okay.
extra comment. I guess I'm not very comfortable commenting on member states that are not my own, but from what I've seen these last days and the presentations we've seen, I guess it would be fair enough to fight for getting some of the taxes from alcohol, tobacco into fighting for better health literacy. If you want to fight inequities, you better get your people educated.
Thanks. Maybe I can add one thing. On the other hand, as far as I know, so I have the same problem that we don't probably know so well Scottish situation that we can comment it so very freely. But on the other hand, what I've heard from outside is that Scotland has quite a lot of policies, quite a lot of differences compared to other neighboring nations, which are to say supporting equity quite well. And I would also advise your minister to keep that difference and that kind of what do you say line of developing the society.
Thank you very much.
Okay. One thing that has not yet been mentioned in the table is the health literacy. I mean, when we still listen that beer is good for your health, eat chocolate that will improve your health in one way or in another, and that there are people that are following those advice, I ask myself if one of the issues is not that, we know that the education is a basic thing, but in general, because improve the health, but also the health literacy, even for the educated, that will not be an area where we have to still have a lot of work to do. Do you agree? Okay, any other question? Yeah. Down the micro.
Can I be very controversial and say that I was rather disappointed in that result, in the answers to that question? Because here we have an opportunity with a country that actually is prepared to take quite a radical approach in very difficult circumstances. And it's a theme that's come out. I've been here since Thursday, and it's a theme that's come out about whether, as public health professionals, we are actually colluding on this area of, I think, was termed denialism, because we talk about social determinants of health and we talk about health in all policies, and yet when it comes to practice or actually giving some recommendations about, say, to Scotland's First Minister, we come back with the issue of health literacy, which puts the onus and, in a sense, the blaming back on the victims. Is health literacy actually going to make any difference when all the discussion is about social determinants of health and health in all policies? You know.
I appreciate the question, and I think it's controversial, but it's an important discussion to have. And on the Twitter feed, it's saying it's hard to advise a minister when you want concrete answers, right? I personally don't know the Scottish situation that well. But what I do know is that if we are unable to do health in all policies, things won't work. And from my perspective, education is part of health in all policies. It's not the only solution, but it's inevitable that you have to put education in the formula. And the consequences will not be in 2 years or 5 years, but you'll have a next generation of people that will be able to use the public health recommendations in their own good. This is not a sense of blaming them or saying that we don't have other social problems. You probably do. I don't know them that well. That's why I don't comment. What I do know is in general, and from what I've seen, I mean, what I saw, I was shocked, to be honest, to see the life expectancy in Eastern Glasgow. The numbers are unacceptable for a country like Scotland. And in that sense, I really feel that there's probably a long way to go, and education has to be part of it. Because getting back to Portugal, which is my country, we have many actually pretty good public health programs, but at the end of the day, people that are not minimally prepared or conscious about their health and are not literate enough when it comes to health, they end up not being able to use those tools that are given to them in the best fashion. But this without saying that you have to do all the rest, as Gordon, pointed out very well in his presentation. And so, don't see it as a one-way street. It's a multiple-way street to get to a common goal.
Before finishing, 1 minute final statement. Ilmo.
Okay. What to say? So we have heard many solutions. So I can reiterate one, take-home message. It is that we know solutions already, or at least quite a lot of them. So the problem is the implementation. How we implement all these great ideas, health in all policies, good universal health services, improving health knowledge, health literacy. That's true. There is not only one solution. There is not only one final solution for this. We need to improve many aspects of our societies, and then we can reach the objective of diminishing the health differences among the populations.
Andrea?
For me, the final message would be that it's about community engagement and collaboration. I believe that, especially when it comes to the health inequality, there is no single organization that it can tackle, that can tackle this issue. And I fully agree with other panelists that it's definitely not just the responsibility of the Ministry of Health, but other people need to come on the board and become equally responsive to the needs of the citizens. So obviously it includes the social sector, employment sector, housing, transportation, but we shouldn't forget also about the positive possible role of the third sector and volunteers. So I think that we really need to be sure that we try to find the mechanism how to engage our communities from the bottom, how we to make sure that we find the mechanism how to listen to our people and be responsive jointly to these needs.
Thank you. Gaude. 1 minute.
Okay. I wanted to answer Sylvain. I wanted to answer. So I tried to give a concrete example when I said minimum unit pricing for alcohol as a symbol rather than just a one solution. I actually think that if you look at the range of interventions that I have suggested in the different interventions that I've made, measure. We need to assess. We need to know who is and which groups are most affected. Make sure that the state does not abrogate its own responsibility to intervene. Increasingly, within politics, we are finding this language that shunts the responsibility onto the victim. These behavioral interventions that take over environmental. Look at the life stages. If people have a healthy early start to life, this is the responsibility of the education sector, of the social sector, of the health sector. Early childhood development sets a very strong trajectory for the rest of life. And don't undervalue the importance of the known interventions, the specific policies that work. name the range from pricing to marketing controls, from health promoting settings, through to working across with other social welfare departments to just make sure that we are looking at the other causes, employment, income. So making one letter to one minister in one country is going to be a long one. We can at least provide as practical and as concrete a checklist as possible.
Thank you. And Ricardo, final remark.
I think I've already talked too much. Just say that.
30 seconds.
Just to say that if we really want to battle health inequities, we have to get it stronger, and maybe just reinforce something that Andrea said that I didn't mention before that I truly believe in is sometimes when you need to get to the most vulnerable populations, formal health institutions are not very good to getting there. Getting the NGOs on board, getting the informal settings, finding strategies to get to those populations and being effective, coming from the field of HIV and hepatitis, I can say that is a very effective strategy, and I believe that all of Europe can benefit if we're able to put formal institutions, politicians, and NGOs working stronger together.
Okay, so thank you very much. If I can conclude, so the main discussion said that even if we have advanced, we have still need for further action to address the health inequalities, that for that we require a coordinated approach across different policy sectors, that the European Structural and Investment Funds were mentioned that could promote the social inclusion and combat poverty and promote community-based integrated approaches to healthcare and social care. Quote, I have to say that for this next period, the total envelope is 351.8 billion euros for the social and investment fund. Integrated care can improve the quality of care for people with long-term conditions. Also, was mentioned that we need to shift in resources to effective early interventions and access to preventive care. The provision of technology-enabled care was mentioned, that the services should be tailored to the needs of the people, that no, it's not true that one size fits all, that we have different approaches and processes to the implementation of integrated care in the different countries of Europe. We need a focus on health promotion and effective prevention, and we need awareness, political leadership, and commitment to implement these integrated approaches that could help us to mind the gap for vulnerable groups and to have a fairer health in Europe. So thank you very much and have a good lunch.